Hi, I'm Ursula Matulonis, and I'm from the Dana-Farber Cancer Institute in Boston, Massachusetts, and a real pleasure to be here for the year in review for Research to Practice. It's always a pleasure being part of these programs. So I am going to focus on ovarian cancer and what has happened over the past year. We're going to talk first about newly diagnosed ovarian cancer, and then I'm going to pivot to patients with recurrent ovarian cancer. And I think some new findings have occurred, and I think some studies, which we'll talk about, have more questionable findings and may just need more time. So PRIMA was presented at ESMO. Brad Monk presented at ESMO, and then kind of a simultaneous presentation in the Annals of Oncology last year. And then certainly we were waiting for PRIMA OS results to come to really help us decide, do we use PARP inhibitors in everybody, specifically niraparib, where it currently has a full approval, or should we tailor the use of a PARP inhibitor based upon the HRD status? Then first, that just happened at ASCO 2025, comparing PARP inhibitor maintenance to PARP inhibitor maintenance plus an immuno-oncology agent, specifically dostarlimab, in patients with newly diagnosed ovarian cancer in response to platinum-based chemotherapy. And then the KeyLink trial that was presented at ESGO in a presentation, and then SGO again as an oral presentation. We don't have a paper yet. And then an update on the PAOLA-1 trial, just an interesting article from the International Journal of Gynecologic Cancer about PFS and OS based upon a risk of recurrence. So the PRIMA study, everybody knows, this is a trial of advanced ovarian cancer patients, high-grade serous, high-grade endometrioid, in response to 6 cycles of chemotherapy, and then were randomized 2-to-1 to either niraparib versus placebo, and the primary endpoint here was progression-free survival. It's important to remember on all these studies where you think about survival, is that subsequent PARP inhibitor use occurs, and that would only be natural, both in the patients who received a PARP inhibitor, and then even in obviously the patients who are received placebo. So for the niraparib treated group, even some of those patients were treated in the recurrent setting, but in the placebo group, specifically of those patients who have HRD present cancer, it was almost 50% of patients received subsequent PARP inhibitors. And just something to remember. Obviously, in the United States, the FDA approvals have been altered in the past 2 to 3 years, where we can only use PARP inhibitors in the BRCA mutated setting, in the recurrent setting. But in the upfront setting, obviously, we can use, based upon PRIMA, niraparib for all patients, regardless of BRCA status or HRD status. So here are the very eagerly awaited overall survival results. And initially, overall survival was tested in the overall population, and that's an A in the upper left or the top curve. And that did not show any improvement from an OS perspective when niraparib was given. So formal OS analysis of the HRD population did not occur based upon the statistical section. And I think, so here, overall population is an A, really no difference. And then HRP over to the right, and then HRD to the below. And there's no improvement in overall survival. Even in the HRD, not even a trend towards OS improvement. Obviously, the trial was powered for progression-free survival, not for overall survival. Now, I think it's very interesting when you delve in a little bit further, and these were not necessarily formally analyzed, but you can see the curves here. So the top curve here, further OS, is HRD positive BRCA mutated, and not much of a difference in the survival curve. And that is of interest because that's not totally what we saw with Solo 1. All these trials do show progression-free survival benefits with the use of a PARP inhibitor, which is most pronounced in patients with an underlying either somatic or germline BRCA mutation. But there was a trend towards OS improvement in Solo 1, which we're not seeing here. And I think that's an interesting finding. So this is really the PRIMA OS results have really changed my practice. And I definitely have a conversation with patients who have HRP, homologous recombinant proficient tumors. But because of the rather minimal progression-free survival benefit, and here we're not seeing any OS benefit, I am deprioritizing the use of a PARP inhibitor in the HRP setting. Now, the first study we just heard about a few days ago at ASCO 2025. The first study initially had 3 arms to it. One was a standard of care arm, so just chemotherapy. Arm 2 was chemotherapy plus or minus Bev, followed by niraparib maintenance. And then arm 3 is chemotherapy plus dostarlimab plus or minus Bev, followed by niraparib and dostarlimab with or without Bev. But due to the approval of niraparib in the first-line setting, arm 1 was closed, and then participants were subsequently randomized 1-2 to either arms 2 and 3. In this trial, again, advanced high-grade serous high-grade endometrioid patients receiving carboplatin and paclitaxel. Primary endpoint here is investigator assessed progression-free survival in arms 2 and 3. And if PFS results were significant, then OS testing would continue. And there was a press release a few weeks ago saying that, yes, in fact, PFS was significant, and that the results would be presented at ASCO. Interestingly enough, there was also a subset of patients with PD-L1 or HRD positive and those with concurrent bevacizumab. These patients were identified a priori as a clinically plausible group to have kind of special or differentiated results. So the next few slides show these results. So these are the progression-free survival curves. Median PFS was 19.2 months for niraparib alone. And then when adding dostarlimab, it increased a little bit more. It was about a 1.4 month median PFS improvement. Then when looking at the PD-L1 population, really not much of an improvement here. And this is the population that one might consider having additional benefit from dostarlimab. OS was also presented, 57% maturity for OS, and these curves are overlapping. So I think in terms of the first takeaway points, really essentially the same or relatively comparable progression-free survival benefits of adding dostarlimab compared to not adding dostarlimab, 1.4 months difference in the median PFS. There was no overall survival benefit of adding dostarlimab to niraparib maintenance, and that PD-L1 biomarker did not predict the impact of the checkpoint inhibitor. In this particular trial, patients could have received Bev or not. About 50% of patients did receive bevacizumab. And I think, as the paper comes out, one would want to see, does the receipt of bevacizumab influence therapy outcomes? Probably not, but it would be interesting to see. Dr. Graybill in the International Journal of Gynecologic Oncology actually looked at PRIMA. So first, of course, is not in a paper yet, but PRIMA is. Dr. Graybill did a post hoc analysis to determine the factors predictive of long-term disease-free survival. And I don't think the findings were particularly surprising, but basically looked for progression-free survival 2 years or more, and essentially HRD positive cancers. I say HRD, so an HRD cancer, either BRCA1 2 mutated or BRCA wild type HRD. FIGO stage 3 versus 4, so perhaps slightly better outcome. And then 0 or 1 baseline non-target lesions versus greater than 2. So again, potentially better prognostic disease is going to predict for a longer progression-free survival. So interesting, but not too surprising. The next 2 trials are other studies that have examined the combination of an IO agent with a PARP inhibitor. I'll tell you my thoughts on all of this, but this is the KeyLink trial presented at ESGO and SGO. Again, advanced non-BRCA, this is non-BRCA specifically, mutated, newly diagnosed ovarian cancer, stage 3-4, high-grade serous. The treatment arms are carboplatin paclitaxel, second arm carboplatin paclitaxel, pembro, followed by pembrolizumab maintenance, and then the third arm adds olaparib as maintenance to pembrolizumab with pembro added to chemotherapy. In this trial, all the arms could be given with or without bevacizumab, and there's no PARP inhibitor alone maintenance arm. And these are some of the results that were presented at ESGO specifically. The results really focused in on patients whose tumors had a CPS score of 10 or higher. And you can see on the right, there was an interim analysis 1 and also the final analysis. And there's really not too much difference between the interim analysis 1 and the final analysis. And the significance threshold of pembrolizumab versus control in the CPS 10 population was not met, and thus formal testing of PFS in the overall population and OS was not performed. But on the right, you can see here, pembrolizumab olaparib versus control was examined, and then at the bottom, pembro without the PARP inhibitor versus control was examined. And in terms of progression-free survival, adding the PARP inhibitor did improve progression-free survival. However, when it's just pembro alone, no PARP inhibitor, there's a trend towards a little bit of an improvement in PFS, but the confidence intervals crossover 1. And then DUO-O was another trial. This trial testing durvalumab. Here, advanced ovarian cancer, non-BRCA mutated patients, treatment naive, etc. 3 arms, patients could have been randomized 1:1:1, either carboplatin paclitaxel with Bev maintenance, carboplatin paclitaxel, Bev, and then durvalumab added. And then the third arm, olaparib is added as maintenance. And again, there's no PARP inhibitor alone arm. And here, the 2 populations that were examined were the non-BRCA mutated HRD positive, and then the non-BRCA mutated intent to treat population. And here are those results. There was an improvement in progression-free survival for arm 3. That's where the PARP inhibitor is added to the backbone of carboplatin paclitaxel Bev plus durvalumab. But in terms of the arm that just added durvalumab, that, again, a slight improvement in PFS, but I don't think particularly clinically meaningful. And then the intent to treat population was pretty much the same, increase in the PFS when the PARP inhibitor is added, but immunotherapy alone added to chemotherapy and then as maintenance really is having just minimal effect. We're not seeing a negative effect like we have with other trials, just not a particularly robust added effect here. And this is interim overall survival, and really no differences here in overall survival at this time point. So both of these studies do not have the control that one would consider for standard of care as having the PARP inhibitor as maintenance, so you can't really compare the trial to standard of care. And then based upon these 3 studies, FIRST, DUO-O, and KeyLink, the data do not support adding an IO agent, at least I don't think, adding an IO agent to a PARP inhibitor is maintenance, and neither is there justification for adding a checkpoint inhibitor to chemotherapy or using that as maintenance therapy. PAOLA-1, this was Kettle-LaRusso's post hoc analysis in PAOLA-1. PAOLA-1, remember, is patients receive chemotherapy with Bev and then are randomized to either Bev alone or a PARP inhibitor added to bevacizumab. And the patients were broken down based upon risk. So a higher risk were patients with stage 3 disease who had upfront surgery and had residual cancer, received neoadjuvant chemotherapy or had stage 4 disease. Patients with lower risk disease had stage 3 and had upfront surgery and had a complete R0 resection. Most of the patients in this trial had higher risk disease, 3/4, 25% were lower risk. And in this particular trial, what Dr. LaRusso found was that really there was a benefit of using the combination of bevacizumab and olaparib in really any patient with an HRD positive cancer, and that's what the results have shown, and that's where the FDA approval exists. And in the patients with homologous recombination proficient tumor, there's no benefit, regardless of the risk of the type of or a patient that you're seeing. So, and there's not an indication here at all to use Bev and olaparib in a patient with a homologous recombination proficient tumor. Moving on to recurrent ovarian cancer, a lot to talk about here. Exciting results on avutometinib and defactinib. The Rosella trial, Keynote B96, just press release, raludotatug, deruxtecan, and Mirasol final OS results. So this data has been presented many times, and I think is, it's really exciting data, and is really an improvement for patients who have a RAS mutated low-grade serous carcinoma. Rachel Grisham presented this at SGO, but it's been presented multiple times in different meetings. Avutometinib is a RAF-MEK clamp, so it blocks both RAF and MEK, and it prevents feedback reactivation from ERK back to RAF, and it also prevents stimulation of FAK. And through defactinib, there's also FAK inhibition. So it's a really pretty neat combination based upon the biology that is really driving a low-grade serous carcinoma cell that has an underlying RAS mutation. This combination was granted accelerated FDA approval on May 7th, and I think we'll be using this very shortly when it becomes available. This is the RAMP 201 data, again, that has been presented multiple times and has led to that accelerated approval. The number of patients is 115 through these blue, so the selection phase, expansion phase, and expansion phase combo. Of this dosing on the bottom left here is a avutometinib dose of 3.2. So patients will take 4 0.8 milligram capsules twice per week, so day 1 and 4, for the first 3 weeks of each 4-week cycle. And then they're given defactinib, 200 milligrams twice daily for 3 weeks out of the 4 weeks. Other schedules were tested, so there was a lower dose combination, and then there was just avutometinib alone, and both of those really produced inferior results. So these are some of the high-level results that have been presented, and I'm sure we'll see in the FDA package insert and in a manuscript. But a very impressive waterfall plot, and we're seeing an overall response rate of 44% for patients who have specifically a KRAS mutation. So we also can see NRAS mutations in low-grade serous, but here's KRAS mutation. For KRAS wild type, the response rates are there, but it is lower at 17%. That duration of response is pretty impressive. So for KRAS mutated patients, the duration of response is 31.1 months. For wild type, it's 9 months. The median PFS, 22 months for patients who have a KRAS mutation in their cancer versus 12.8 months in KRAS wild type. So it's understandable why the accelerated approval is happening in the RAS mutated part. These are some of the results that Dr. Grisham presented at SGO. and some of the factors that play into the level of response rates that patients are seeing. So here, and the pink bars are the RAS mutated patients. So this is a prior MEK inhibitor, yes or no. And if a patient has not received a prior MEK inhibitor, the response rates are higher. Prior BEV, if patients have not received prior BEV, and this is also true of chemotherapy in ovarian cancer, response rates are higher. And then what we see with a lot of treatments, the more heavily pretreated patients greater than 3 have 36% rate versus 49% for up to 3. Toxicities, 80% of patients had adverse events that led to dose interruption. A little over a third of patients had adverse events that led to dose reduction. About 10% of patients discontinued treatment because of adverse events. And the most common reason for this was an elevation of CPK, and that's found in a routine blood test. And both of the drugs seem to be able to lead to an elevated CPK. So great study, terrific results. We're going to be using these, and I think really is a win for patients who have a KRAS mutated low-grade serous cancer. Really a major improvement in treatment. The Rosella study was presented at ASCO, and then had a simultaneous publication in Lancet. The glucocorticoid receptor, which is the subject of this study, is a nuclear hormone receptor and transcription factor activated by cortisol and then treatment with glucocorticoids. One of my former faculty at Dana-Farber, who's now at GSK, Jen Veneris, when she was at the University of Chicago, noted in some really interesting papers that increased glucocorticoid receptor expression is associated with decreased overall survival in ovarian cancer patients. It also seems to lower the ability for chemotherapy to be efficacious. And in vitro, what happens is that the glucocorticoid receptor activation inhibits chemotherapy-induced ovarian cancer cell killing, and it's thought to occur because of transcriptional upregulation of anti-apoptotic genes. So that makes the chemotherapy work less. So by modulating or inhibiting that receptor activity in combination with chemotherapy may improve patient outcomes. So you're basically, lessening that transcriptional upregulation with the antagonist of the glucocorticoid receptor, but then you're also adding chemotherapy that's now going to work better. There was a randomized phase 2 study that our group participated in, and that basically was looking for different schedules of nab-paclitaxel. And the reason nab-paclitaxel was chosen was because it does not require steroid pre-medications. And two types of schedules were looked at. One was an intermittent relacorilant schedule where you give relacorilant 150 milligrams the day before, the day of paclitaxel, and the day after, versus continuous relacorilant versus nab-paclitaxel monotherapy. And the reason that the nab-paclitaxel dose is lowered here to 80 milligrams per meter squared when you combine with relacorilant is because of CYP3A4 interactions. And in this trial, the schedule 1, so the intermittent relacorilant, was chosen because it had better efficacy. And that was moved into the Rosella study design. So this is a phase 3 trial, unblinded, open label, and this is taken from the supplementary section in the paper. Patients on the top, this is the experimental arm, nab-paclitaxel, 80 per meter squared, days 1, 8, 15 out of a 28-day cycle, and then relacorilant day before, day of, day after, versus nab-paclitaxel 100 milligrams per meter squared. And that is the trial design. The study, basically, if a patient had to come off one of these two drugs, it seemed, and I looked at the study very carefully in the supplementary section, it did appear that the patient would stop treatment. The patient wouldn't continue on nab-paclitaxel alone if she had to come off relacorilant or vice versa. So these are some of the statistics. So there was a dual primary endpoint, PFS, and with a 1-to-1 randomization, 230 events could show that the study had an 86.4% power to detect a 50% increase in progression-free survival. OS was allocated to a two-sided alpha of 0.01 significance. And if that PFS null hypothesis were rejected, then the alpha would be tested at 0.05. So what we've seen here at the ASCO presentation and the paper is the interim analysis. So the interim analysis is interim. The progression-free survival statistics were performed per the stats plan. The OS was conducted at an alpha of 0.00030, and the formal OS analysis will be conducted later. So these are the results from the paper. The PF was termed statistically significant. Hazard ratio was 0.54 to 0.91.7, with approximately a 1-month improvement in median progression-free survival. OS, the curves look interesting, but this is all preliminary work, and these are interim analyses, and the log rank P here is 0.01. Remember, it had to hit 0.0001, so it is not significant and is still very much preliminary. These are some of the toxicities. So for dose reductions due to adverse events, 50%, nearly 50% of nab-paclitaxel had to be dose reduced in the combination arm, and about 30% in the monotherapy arm. There was a higher rate of grade 3 or higher neutropenia and anemia, and in the combination arm, the rate of grade 3 or 4 higher neutropenia was 44%. And for nab-paclitaxel alone, it was 25%. So I do have some reservations about this study, and I think we'll have to really wait for the final results. This data represents an interim analysis. The OS benefit is not statistically significant, and the PFS benefit is a month. It's non-blinded. Nab-paclitaxel, yes, it's on the NCCN guidelines, but we do not use it standardly. It's higher toxicities compared to weekly paclitaxel. Similar efficacy, but I think more myelosuppression. No control over what patients receive post-treatment. There's really a mix of ovarian cancer histologies enrolled. So these are patients with high-grade serous, high-grade endometrioid, and carcinosarcoma. Kudos to the team for allowing carcinosarcoma, but we're going to have to see what the mix is in the two different populations. Based upon Jennifer's work, that level of expression of the glucocorticoid receptor seemed to be important in outcomes. But in this trial, we don't see a specific quantification, and it's not being used as a biomarker. And as I mentioned already, there's a higher rate of grade 3 for neutropenia and anemia in the experimental arm. B96, I'm just going to say a few words about because we haven't seen anything. This is based upon a press release a few weeks ago. This is a trial predominantly done in Europe, phase 3 randomized double-blinded trial of Pembro plus paclitaxel, weekly paclitaxel, plus or minus bevacizumab versus weekly paclitaxel plus bev. And in terms of the eligibility, platinum-resistant ovarian cancer up to 2 prior lines of chemotherapy. Primary endpoint here is progression-free survival by the investigator in patients with PD-L1, CPS 1 or higher, and in all patients as well. These are the, planned accrual was 643 patients. The Pembro dose is given on a 6-week schedule, 400. Paclitaxel here, 80 milligrams per meter squared per week on a 3-weekly schedule. Press release a few weeks ago showed that the trial met its primary endpoint of progression-free survival for platinum-resistant ovarian cancer whose tumors expressed PD-L1 and in all comers. And the study also met a secondary endpoint of OS in patients whose tumors did express PD-L1. Interesting results. We'll have to see the presentation in the final paper. When thinking back to Keynote 100, that was published in the Annals of Oncology in 2019, and this was testing, first time we tested pembrolizumab alone in platinum-resistant ovarian cancer, and really also took a very deep dive into the molecular determinants and really couldn't find anything. But one clinical factor that did appear to be interesting was the CPS score, looked at less than 1 or higher, and then 10 or higher. And the response rates goes from 4.1% to 5.7% to 10%. So hence why that higher CPS score is looked at in ovarian cancer to determine if there's going to be more benefit. Okay, finishing up with a very exciting topic of antibody-drug conjugates. At SGO, Dr. Van Gorp presented final overall survival results of Mirasol. This is if you all recall, a phase 3 trial of mirvetuximab, antibody-drug conjugate with a DM4 antimitotic payload against folate receptor alpha versus investigator's choice chemotherapy, weekly paclitaxel, liposomal doxorubicin or topotecan, up to 3 prior lines, FOLR1 positive, and then patients were randomized 1-to-1 to MIRV versus investigator's choice chemotherapy, non-blinded. Primary endpoint here was PFS by investigator, key secondary endpoint OS, duration of response, overall response rate. And these are the final OS results, which stood up to more interim analyses, and there's a statistically significant improvement of overall survival for mirvetuximab versus investigator's choice chemotherapy. So an active drug in patients with recurrent platinum-resistant ovarian cancer, not heavily pretreated up to 3 prior lines, who have a folate receptor alpha positivity. And then Katie Moore presented data at SGO on raludotatug deruxtecan. That is an antibody-drug conjugate with a deruxtecan payload, TOPO1 payload, against CDH6, and certainly very impressive overall responses. And this is regardless of the biomarker. So this is a drug that clearly has an advantage of, yes, it's very active, and does not require a biomarker. And so this is a slide that she showed. The PRs are in purple. The CRs are in dark, not many CRs. But you can see that on the left, the lower membrane intensity, and there are definitely responses, maybe slightly more towards the right. So definitely an active drug. And then just talking about 2 other folate receptor alpha medications that have been tested in the recurrent setting. Rinatabart sesutecan. This was data presented by my colleague Betsy Lee at SGO in 2025, looking at 2 different doses of rinatabart, or Rina-S, the 120 and then 100 milligrams per meter squared, showing a nice response rate of the 120 of 55.6%, and then a slightly lower response rate in the 100. This is a drug that is moving on to the phase 3 trial in the platinum-resistant ovarian cancer space that is not requiring a specific folate receptor alpha level of positivity. Luvaltamab tazevibulin is a medication that is an ADC, a mitotic payload, antimitotic payload that is currently in phase 3 testing right now. And this is looking at 2 different doses. Basically, there was a press release a few days before SGO 2025 that said that Sutro was going to deprioritize luvaltamab development. And then at SGO, these are the results. And you can see that the higher dose of 5.2 milligrams per kilo had about a 32% response rate, and the lower dose where patients have to go down to, because there's definitely significant myelotoxicity with this drug, there's only about a 14% response rate. So these are the ongoing phase 2 and 3 antibody-drug conjugates trials in ovarian cancer, and this will continue to evolve with time. In the first-line setting, trastuzumab deruxtecan is being tested as maintenance. In the second-line platinum-sensitive setting, sacituzumab tirumotecan, or SAC-TMT, is being tested, and then Gloriosa and mirvetuximab. And in the platinum-resistant setting, all the drugs I've just mentioned, so luveltamab, tazevibulin, raludotatug, or Reludo, is being tested against investigator's choice chemotherapy in the platinum-resistant setting. And then the Rinatabart study, or the Rainfall OV2, is just opening. And this is, again, anti-folate receptor alpha, antibody drug conjugate, topo-1 payload, no biomarker needed. So really, the Reludo and Rinatabart are going to be kind of going head-to-head for a very similar population. So thank you so much. It's been a pleasure to update you on what's going on ovarian cancer, and lots more to come, over the next year for sure.